So hello everyone. My name is Aditya Karthik and I am from San Jose, California. And I attend Evergreen Valley High School out in the Bay. So the research I was involved in was an examination of different regenerative therapies for knee OA. So I examined different stem cell sources, therapies, and tried my best to really come to a conclusion as to which therapy might be the most beneficial to invest in for the future. And through this entire process, my mentor was Sophie from the University of Toronto. So much thanks to her as she guided me through this entire process. So what is knee OA? So our knees withstand a great deal of force. So when walking, knees can bear up to 3 times of our own body weight. And this number only increases with more complex motions, such as even getting up from a chair. Knee OA is a degenerative condition that arises as the result of the wearing down of the muscle and cartilage of the knee joint over time. It impacts the articular cartilage and bone of the knee. More specifically, it impacts 3 areas of the knee: the medial, the lateral, and the patellofemoral joints. And these 3 facets of the knee work together that allow our knee to bend and contort in the way that it does. Knee OA is multifactorial in origin, with a few risk factors being modifiable, such as excessive lifting and weight. However, most risk factors for knee OA are hereditary, and meaning they are out of our control. So right here, we can see the differences between a healthy and osteoarthritic knee, and both an X-ray and a model that I created. In both cases, we could see the narrowing of joint space that occurs, as well as other erosion of different parts of the knee, including the meniscus, the bone, and other ligaments. One may ask, well, why did I decide to choose this degenerative condition as opposed to the many other degenerative conditions that exist? Well, knee OA is one of the leading causes of disability, affecting upwards of 250 million people globally. In fact, hip and knee OA combined for over 17 million years lived with disability globally. Even more, there has been a much more concerning trend, which is an increase in the rate of younger people that develop knee osteoarthritis. So, as we know, as knee OA is a degenerative condition, knee OA is much more likely to impact seniors. In some form, it has been found to be over 33% of seniors that can develop knee OA. However, it is also concerning to see that there is a growth in osteoarthritic rates in younger people as well. This may be as a result of a variety of factors, including minor sports injuries or even major tears or breaks in the knee. Over time, knee injuries as a result of sports have become more and more prevalent due to increased demand and competition in sports all across the board. More, it is estimated that at least 3.89 children and adolescents sustain some kind of knee ailment per 10,000 exposures to sports. This could include practice, games, etc. And studies show that 33% of young adults in their mid-20s show signs of early onset knee OA within 1 year of a traumatic knee injury, such as an ACL tear. Over time, this number only increases from 33%. And taking your attention to this graph, we can see that from 1995 to 2015, there were significant increases in OA prevalence across the board in this cohort in all age ranges. But specifically, we see that at this very line at the bottom, which encompasses people from the ages of 45 to 54, we see that this increase has the greatest statistical significance, increasing from a number below 2% of prevalence in the cohort to a number upwards of 3%, which is a very concerning trend, as knee OA isn't something that we have seen in people this young in years past. So, what are some of our current treatment options for knee OA? In terms of operative treatments, we typically see patients undergoing knee arthroplasties, whether this is a partial knee replacement or a total knee replacement, or a TKA. So other surgical options include arthroscopies and cartilage repairs, which are both much less invasive, but also much less effective. And right here, you can just see this is essentially what happens when you undergo a knee arthroplasty. Is they artificially replace the different components such as cartilage and other ligaments of your knee. So while surgical intervention has been commonplace for years, a big issue still remains, and this is a phenomenon known as PPSP, or persistent post-surgical pain. When a TKA is performed, the body naturally responds with inflammation, which leads to a chain reaction, a positive feedback loop that leads to excitatory neurotransmitters to be released, which activate receptors that could potentially lead to chronic knee pain. Moreover, this contributes to the development of PPSP, which over 10% of those who undergo a TKA suffer from. Even more, over half of patients who undergo a TKA are woken up by pain in the first 3 days. So other people choose this kind of non-operative route when they have knee OA. So that these are more treatments and not cures, which means that we really need to consistently treat the knee, the damaged area, with these therapeutics. These could include, these range from hot, cold compress, and lifestyle changes are usually the biggest non-operative treatment that we see. And the typical lifestyle changes is typically weight loss or healthier eating habits. But the issue with this is that even though this may help the development of further knee OA, we cannot reverse the damage that has already been done in terms of the degeneration of the knee joint. So, on the other hand, using stem cells shows a promise to be a permanent cure for knee OA. When using these cells, our primary goal is to restore and regrow articular cartilage and muscle. Stem cells can be pluripotent and totipotent, indicating that they have the ability to differentiate into numerous forms of body tissue. The most commonly used form of stem cell is the mesenchymal stem cell. These cells can be derived from numerous cell types, including bone marrow, the embryo, adipose, which is from body fat, and much more. Though each source has key differences, all are not immunogenic when used from our own bodies, indicating that we do not need to use some kind of immunosuppressant, and as our body won't produce an immune response to these cells being incorporated into our bodies. More, each cell source differentiates into different tissues, which help regrow key components of the knee. However, sometimes when we use sources from external sources, so this could be other people or cells grown in cultures, immunosuppressants might be required to prevent a phenomenon known as graft versus host disease, or GVHD, where the body rejects foreign cells, leading to potentially dangerous situations, which can be as bad as mortality. So right here is just a quick overview of chondrogenesis, which is the process which a mesenchymal stem cell uses to grow into chondrocytes, which regrow the cartilage in our knee. And right here is just the process of myogenesis, which, similar to chondrogenesis, it starts as a mesenchymal stem cell, but eventually we form the muscle fibers, which are needed for our knee. So now just getting into a kind of comparison between our different MSC sources, when our cells are ready to be added to the defect site, they are typically added through these intra-articular injections to the knee. This could be single injections, multiple injections, but essentially we take a needle and we insert it all the way into the knee. So starting off with bone marrow, we can note that it is a very limited source, as our body produces less and less as time goes on. However, in an environment with no added growth factors, bone marrow has the highest rate of chondrogenic differentiation. More, it is fastest in the recovery process after injection. In numerous clinical trials in which bone marrow has been used for knee OA, bone marrow has rarely shown adverse effects, going as far to show benefits that last for over 5 years in longitudinal studies. Getting into adipose, which is derived from body fat, we know that it has an extremely high yield potential, with one of over 500 times of bone marrow yields, typically through processes known such as liposuction, which are used very often in cosmetic surgery. However, the differentiation is a much slower process, as this kind of stem cell is more of a multipotent rather than a pluripotent or totipotent cell. However, with the addition of cytokine and other growth factors, it can reach a very high rate of differentiation. And the final main MSC source is the synovial MSC, which is derived from the synovial membrane, which is kind of from a joint in our body. It too has higher differentiation potential than bone marrow, of over 10 to 30 times. And when certain growth factors, such as bone morphogenic factor 2 and transforming growth factor beta are introduced, synovial MSCs induce more chondrogenic differentiation from bone marrow MSCs from the exact same amount of donors. And just kind of to wrap up all our stem cells, another form of stem cell with great potential to treat knee OA is the induced pluripotent stem cell. They are made from dedifferentiated adult somatic cells. So essentially, we take a cell from anywhere in our body, and we can reprogram that to be able to differentiate into a specific cell type that we want to. So in this case, it could be the cartilage, the muscle, etc. of the knee, right? And these cells have patient-specific treatment potential because we can take a patient's cell and just insert it back into their body after we reprogram it. And no immunosuppressants that thus would be required. In the limited study of these cells, induced pluripotent stem cells have shown to have a far superior therapeutic impact and showed zero weaknesses in restored cartilage. More, they can be obtained from any bodily cell, which indicates that non-invasive techniques can be used, as opposed to maybe if you were to obtain a cell from the synovial membrane, it would require an invasive kind of procedure to extract those cells. But the biggest issue with these cells is that they are very pricey, as the reprogramming of these cells is a very complex process that requires much, much time. And it's something out of the budget of over 99% of Americans today. However, the biggest positive sign with these cells is that we look at the induced pluripotent stem cell as a boundless source potential, as we can use essentially any cell from our body. So just to wrap it up, as of right now, it is extremely difficult to draw any sort of conclusion as to which stem cell therapy is the best. More clinical trials have to be completed to know where the field needs to be headed. Based off strictly potential, the synovial MSC has shown to be far superior compared to our other MSC sources. Even more, induced pluripotent stem cells have shown to be more effective than synovial MSCs, with the potential for both patient-specific care and faster differentiation. However, for both synovial MSCs and induced pluripotent stem cells, very limited data has been published, and more trials must be done to know if either is a viable option in our already expensive healthcare system. So thank you. Do you guys have any questions?
Yes, thank you. You have quite a lot of questions here, so we won't be able to get through all of them. So let's answer a few of them. The first question you have here is, does the stem cell therapy have to be done with the individual stem cells? And if not, are there any side effects to using stem cells from other individuals?
Absolutely. So the stem cell therapy does not need to be done with the individual stem cells. Obviously, some people don't always have quantities of stem cells that can be used, and really most of the time we see stem cells that are used are from either donors or are from cells grown in cultures. And the biggest issue with using these cells from other sources is that we have to use immunosuppressants to prevent GvHD. But if immunosuppressants are used, then these stem cells can be effective. So we can really use stem cells from anybody, different animal sources, in fact. So there's thousands of sources that we can use for these MSCs.
And then the last question we have here is, do you plan to pursue this further?
So it is definitely something that I'm very interested in, and beyond this project, I would definitely like to get experience, like have more involvement in stem cell therapies, whether it be for specifically treating NEOA or really stem cells for degenerative conditions in really any capacity, as it's something that's really interests me. So whether I pursue this project further is something I don't know yet, but I definitely want to pursue using different MSCs for degenerative conditions further.
Thank you. Thank you so much for your great
No problem.
presentation, Aditya.